Hello everyone, welcome to this video. In this video, we are going to analyze the ECG findings of WPW syndrome or Wolff-Parkinson-White syndrome. If you want to save some time, you can watch this video at 1.5x speed. So before trying to make sense of what is in front of your screen right now, let us go and understand the pathophysiology of this disease. So what normally happens in a normal heart is the atria will contract before the ventricles. So let's not even talk about the atrial contraction. Because atria has to depolarize first, right? So the left and right atria, they depolarize before the ventricles, and that is how a normal conduction, electrical conduction in the heart takes place. So the electrical activity in the heart, it starts at the SA node, and it gets distributed throughout the atria. The atria starts to contract, and in that time some of the electrical activity also, it reaches to the AV node. Okay, AV node, atrioventricular node, AV node, and there's some delay here. There's a delay of 0.1 milliseconds. So this is known as AV nodal delay. There's some delay in the conduction of electrical activity. This allows for the ventricles to contract a little later than the atria, because you don't want atria and ventricles to contract at the same time, because that would not be helpful in pushing the blood out into the systemic circulation or pushing the blood into the lungs, right? If both atria and ventricles contract, that would not make an efficient pump mechanism, right? So there's some amount of delay that is physiological, and after which the electrical activities, they enter into the septa. So they enter into the septa from Purkinje fibers. So there are two bundles of Purkinje fibers. So these are known as bundles. Sorry, there are two bundles of His, right? And from these bundles of His arise the Purkinje fibers that innervate the myocytes, or that innervate the heart in both left and right side. Okay, so the electrical conduction in the left side is a bit more faster than the electrical conduction of the right side. So the Purkinje fibers of the left side are a bit more faster. So this is generally what normally happens. But let's say there is a problem here, because there is a circuit, there is a different circuit, there is a different pathway, there is an alternative pathway for the electrical current in the atria to move to the ventricles. Okay, there is another circuit right here, which obviously does not normally it's not normally present, but it's present in this person, which is allowing current to bypass the AV node. Can you see the AV node is being bypassed? The current is not passing through the normal anatomical or normal physiological pathway. It is bypassing the normal pathway, and it is directly entering into the heart, right? So what problem would this make? The problem this would make is that the ventricles would contract before before they normally would. Because the ventricles contract before they normally would, they are not filled enough. So there is a premature contraction of underfilled ventricle. The ventricles don't fill enough, and they contract prematurely, because of which they will pump out just small amounts of blood. Okay, they will pump out just small amounts of blood, number one. Number two, because each time your atria is contracting, the current is passing into the ventricle, and the ventricles also contract, the heart rate also increases. Because the heart rate increases, even if the person is at rest, the person feels that the heart is pounding in the chest, and that is known as palpitation. So this person will complain of palpitations, and they might be misdiagnosed to have anxiety. Imagine what would happen to this person if this person goes to run, or if this person does any activity that makes the heart pump out more blood. Normally, when a person exercises, the heart will normally increase the stroke volume. It will pump out more blood. Oxygen is supplied to whatever areas need oxygen, and it's fine. Okay, normal people, we tolerate that. But this person's heart, it cannot fill properly. Because it cannot fill properly, because it has to contract prematurely, because there is a stimulus here, a stimulus coming from an abnormal pathway. Because this person's heart does not fill properly, even if there are increase in demands for demand of a more stroke volume. Let's say this person is exercising, so peripherally all the blood vessels or the arteries are dilated. His muscles, his or her muscles, they require a lot of oxygen. even if there is a lot of demand, the supply is less. Why? Because the heart cannot fill properly, and so even if it contracts, it will only push out small amounts of blood, and so the supply will not meet the demand, and because of which this person can even go into syncope. So this person will give you another history of recurrent syncopal attacks. So this person is giving you particularly two histories. Okay, the patient is saying that I faint every time I try to do some work, and that is recurrent. And second thing that this person tells you is that the person also has palpitations, and sometimes even at rest. Okay, the person is just sitting like that, and the person can feel palpitations, chest palpitations, without any anxiety, without any stress, and things like that. So this is what Wolff Parkinson White syndrome basically is, and this alternative pathway is known as bundle of Kent. Bundle of Kent. Now, what happens electrophysiologically? What happens to the current that is passing through this alternative pathway is that it does not utilize the normal Purkinje system. I told you Purkinje system is a very high conduction, like the current the current that conducts through the Purkinje system is a high speed conduction. Okay, because this is not utilizing the normal Purkinje system, the conduction is slow. Okay, the conduction of current is slow because it utilizes intermyocyte conduction. From one cardiac myocyte to another cardiac myocyte, the current flows from one to another cardiac myocyte. It does not utilize, essentially, it does not utilize electrical wires. Okay, that increase the speed. So basically, the ventricular contraction is slow. And what wave in the ECG represents the ventricular contraction or the ventricular depolarization, to be more accurate? It's the QRS complex, right? So if the QRS complex is slow, that means it takes longer time for the QRS complex to trace. That means the QRS complex would be broader. Okay, now let's look at the ECG. With this much amount of information in our mind, let's look at the ECG. So here we have a picture, an ECG tracing of Wolff Parkinson White syndrome. And so what is happening in this ECG is there any problem with the atrial contraction? No, because there is no problem with the atrial contraction. If the person does not have any other comorbidities of the heart, the P wave will be normal. So there's nothing to worry about the P wave. Okay, so there is nothing to worry about in the P wave. Now, generally, when we look at an ECG, we analyze the heart rate first, then we analyze the axis, and then we look at the P wave. But because we cannot analyze the heart wave in this single strip of in this single tracing, and we can also not analyze the axis, we are not doing that right now. So let's jump to P wave. P wave would be normal, so there's nothing to read about in P wave in WPW syndrome, because this is primarily a disease of PR interval. Why? Because the PR interval, which is normally because of this AV nodal delay, the PR interval which normally forms because of this AV nodal delay would be absent there, because all of the current is being short circuited into the ventricles. So what would be of the finding of PR interval in this ECG? What finding do you expect to see in this ECG of Wolff Parkinson White syndrome when you analyze the PR interval? Is that the PR interval would be absent, or the PR interval could be short. So in this ECG, as you can see, there is no PR interval. Okay, so absent PR interval is another finding. So this PR interval is absent. Now let's look at Q wave. What is happening? So for Q waves to form, the electrical activity, they have to pass through the septum, because Q wave, it signifies septal depolarization. But in this condition, a lot of the current is not passing through the septum. It is directly bypassing the AV node. It is bypassing the septum. It is entering into the ventricles directly. So would there be a Q wave? No. So there's no Q wave here. There's no Q wave here. So Q wave would be absent. Right. Now, if Q wave is absent, the RS complex, we would not say the QRS complex, we would just call it the RS complex. So the RS complex, I told you, the current is being conducted via intermyocyte conduction. It is not being conducted via Purkinje fibers. So intermyocyte conduction is very slow. So the RS complex would be broad. The normal QRS complex, it takes about 80 to 100 milliseconds, that is 2 to 2.5 small boxes for a normal ventricle depolarization to complete. From beginning to end, it takes about 80 milliseconds to 100 milliseconds, that is 2 to 2.5 2 to 2.5 small boxes. But can you count here? Let's say if this is the end of atrial contraction and if this is the beginning of ventricular contraction, 1 box, 2 box, 3 box, this is the S wave, and 3 and maybe 3.5 or 3.25, something like that, right? So this is definitely more than 2 to 2.5 boxes, right? So the RS complex would be broadened more than 2.5 small boxes, right? More than 100 milliseconds. Another thing, can you see here? So I told you there's no Q wave here, but generally normally what we would have expected, even if there was no Q wave, we would have expected something like this. The R wave would be something like this, but there is a sloping inclination at the beginning of R wave. This sloping inclination at the beginning of R wave is known as the delta wave. So delta wave is characteristically present in Wolff-Parkinson-White syndrome. Okay, so what would be another finding here is I cannot see any other findings, but one thing which is very important for you to understand here is, let's say this is the beginning of P wave and this is the J point in the ECG. This is known as the J point. The end of S wave is known as the J point of ECG. So if you look at the PJ interval, okay, if you look at the PJ interval, it comprises of PR interval along with QRS complex. Okay, PR plus QRS complex. You know that PR is actually, PR interval, it begins from the start of the P wave to start of the Q wave. So there is no Q wave here and there is no PR interval. Okay, so there is no PR interval. If this is the entire atrial contraction, this should have been PR interval, but there is no Q wave, there is no PR interval, or at least it is shorter than normal. Normal PR interval is about 120 milliseconds to 200 milliseconds, so about 3 to 5 boxes. So it's shorter than 3 to 5 boxes. So even if you count this as about 0.5 boxes, it's definitely short. So the PR interval is short or absent. So this PR interval is decreased and the QRS interval is increased. So it balances it out. Okay, so I told you PJ interval equals to PR interval plus QRS. Because the PR interval is shortened and the RS complex is prolonged, it balances it out. So the PJ interval is normal in the ECG of Wolff-Parkinson-White syndrome. So this was my short video on ECG findings of Wolff-Parkinson-White syndrome. If you found it helpful, please consider sharing it with your friends. If you have any questions, please leave it in the comment box below. If you understood the ECG and if you felt like I've been successful in clearing your concept in Wolff-Parkinson-White syndrome, then please leave a comment down below. Let me read your experiences. If you enjoyed this video, please consider leaving a like. Thank you so much for watching. Subscribe to my channel for similar content in the future. Have a great day.